speak today about vertigo and my stance that Eustachian tube function should be assessed before vestibular function. These are my affiliations and my non-disclosure statement. Today I'll be talking about Eustachian tube dysfunction, ETD. We will start by reviewing the consensus statement definition of ETD so that we are all working from the same definition. I will discuss the early literature on unilateral ETD, which was first known as alternobaric vertigo, ABV. Next, we will review the fact that persistent alternobaric vertigo at ground level shows abnormal vestibular function test results. This will lead me to my point that Eustachian tube function should be assessed before vestibular function. The Journal of Clinical Otorhinolaryngology published the 2015 consensus statement made by an international forum of scientists and physicians with expertise in the field of ETD. They share the definition, types, clinical presentation, and the diagnosis of ETD. The panel agreed that ETD is a syndrome with a group of signs and symptoms which indicate dysfunction of the Eustachian tube. While we obviously agree that ETD is a failure to perform any of the Eustachian tube functions, in actual fact, in clinical practice, ETD usually refers to a problem with the ventilatory function of the Eustachian tube. As such, ETD is defined by symptoms and signs of pressure dysregulation in the middle ear. The panel also presented diagnostic criteria for ETD. To diagnose the condition, the patient must present with pressure disequilibrium, specifically symptoms of oral fullness or popping sensation and discomfort, pain in the affected ear. Patients may also report pressure, clogged or an underwater sensation, crackling, ringing, autophony, or muffled hearing. Vertigo was left off the consensus statement, but has long been associated with ETD. Moving on, we'll now look at the early introduction of unilateral Eustachian tube dysfunction, which was first known as alternobaric vertigo. Alternobaric vertigo, ABV, results from unequal pressure between the middle ears and is usually caused by bilateral middle ear pressures changing at different rates, causing the brain to erroneously perceive the difference as movement. Of note, only unilateral peripheral vestibular function loss can cause an acute true vertigo sensation. However, asymmetrical middle ear pressures as the cause of ABV is highly plausible, and it is often unfeasible to clearly distinguish between unilateral ETD and bilateral ETD. ABV is defined as dizziness, which occurs as a result of asymmetrical vestibular function due to asymmetrical middle ear pressures. According to FW Medical, vertigo associated with ETD is caused in most and perhaps all instances by unilateral Eustachian tube obstruction or by more complete obstruction on one side. In the consensus statement, barrow challenge-induced ETD was mentioned as a result of alteration or fluctuation in ambient pressure. Barrow challenge-induced ETD can cause alternobaric vertigo when the fluctuation in pressure causes asymmetric middle ear pressures at ambient pressure. Alternobaric vertigo is a relatively obscure condition, which was first coined by Dr. Claes Lundgren in 1965 to describe vertigo in deep-sea divers. It is also used to describe vertigo in aircraft pilots. In both instances, ABV is a result of asymmetrical middle ear pressures. Importantly, though, this diagnosis can also be applied to cases at ground level. No matter how minute the difference in pressure is, ABV is more common in individuals with pre-existing narrow tubal lumens. Of note, cases of insidious ABV are most likely to be overlooked because gastrointestinal symptoms are predominant. Extraesophageal reflux can reach the nasopharynx, which is located near Eustachian tube opening. The vestibular emetic linkage phenomenon occurs when vestibular stimulation impulses pass along the vestibular nerve to the central nervous system and activate the emetic centers in the brainstem. Due to extraesophageal reflux caused by autonomic symptoms triggered by ETD, gastric contents can reach the nasopharynx. In this manner, Eustachian tube dysfunction can cause nasopharyngeal reflux, and nasopharyngeal reflux can cause Eustachian tube dysfunction. I'd just like to make some quick comments about ETD and COVID. There is a rumor going around that COVID-19 causes vertigo. This is not actually the case. As more and more people wear masks to slow the spread of COVID-19, the incidence of the Toynbee phenomenon and alternobaric vertigo increases. This occurs when people perform a swallowing movement at the same time as their nose is obstructed by the mask. Another important point to note is that the nasopharyngeal swab used for the diagnosis of COVID can cause ETD, especially when vigorously or incorrectly performed by causing trauma to the opening of the Eustachian tube. By transferring secretions or reflux gastric content from the nasopharyngeal region to the Eustachian tube. In 1942, FW America declared that vertigo caused by obstruction of the Eustachian tubes is a distinct clinical entity. And he mentioned many patients suffer unnecessarily the distressing symptoms of vertigo, nausea, and vomiting, sometimes for long periods, because their physicians fail to recognize the cause and to institute the simple procedure of mechanical inflation of the Eustachian tubes, which would bring them relief. He is talking about Eustachian tube catheterization. Eustachian tube catheterization can be used for diagnosis and therapeutic purposes. The first case of alternobaric vertigo and Eustachian tube catheterization was reported by Nicolas Delot in 1837. He described a patient who presented with vertigo, tinnitus, and hearing impairment. He treated the patient by catheterizing the Eustachian tube and administering an air douche, which relieved symptoms. In 1871, Peter Allen, a British pioneer of otology who was well before his time, mentioned that vertigo due to ETD was relieved by local treatment using air douche. Not only that, he also correctly maintained that vertigo is associated with intra-auricular pressure, that is, pressure upon the labyrinth fluid. Clearly, we have long known about alternobaric vertigo and the fact that Eustachian tube catheterization is a safe and reliable treatment option remains undisputed. Let's move on to the next section. Persistent alternative vertigo at ground level shows abnormal vestibular function test results. In 2012, for the first time, Dr. Charles Bluestone published a case report documenting a case of persistent alternative vertigo at ground level. He reported that the pathogenesis of the otitis media in such individuals may be related to abnormal anatomy causing ETD. An important point mentioned in this article is that persistent ABV at ground level is associated with abnormal vestibular function test results. ETD also occurs frequently at ground level for many reasons, including nasal obstruction with the Toynbee phenomenon, viral or bacterial infection, and nasopharyngeal reflux due to GERD, gastroesophageal reflux disease. Bluestone reported that in this patient, the vestibular function test results was abnormal, and Eustachian tube function test revealed dysfunction of the tube. In order to relieve the Toynbee phenomenon, surgery was performed to replace the obstructed ventilation tube with a patent one. Adenoidectomy and bilateral inferior turbinate reduction were performed to relieve chronic nasal obstruction. Post-operatively, the Eustachian tube remained dysfunctional. However, vestibular function test results returned to normal, and vertigo was completely resolved. He concluded that nasal obstruction and the Toynbee phenomenon may be involved in patients who have vertigo. This case study has three key takeaways. One, persistent ABV at ground level is associated with abnormal vestibular function test results. Two, mechanically opening an obstructed tympanostomy tube does not normalize Eustachian tube function. And three, nasal obstruction and the Toynbee phenomenon may be involved in vertigo. Bluestone mentioned in his book, one of the most important reasons for assessing Eustachian tube function is the need to make a differential diagnosis in patients with intact tympanic membrane without evidence of otitis media, but with the symptoms potentially related to ETD. J. Mellon recently published a review of dive fitness recommendations and concluded that it is imperative that ABV should be differentiated from peripheral causes such as Meniere disease, benign paroxysmal positional vertigo, and vertebrogenic dizziness, as well as central disorders. Here is the final section. I'm going to discuss why Eustachian tube function should be assessed before vestibular function. Vestibular organs are always influenced by middle ear pressure, which makes them dependent variable organs. Obstruction of the Eustachian tube disturbs air pressure in the middle ear. Specifically, negative pressure in the middle ear can cause the tympanic membrane to retract, which in turn causes the stapes to push against the oval window. It is very likely that dysfunction of the vestibular organ is caused by poorly regulated pressures in the middle ears. So why should Eustachian tube function be assessed before vestibular function? The changing middle ear cavity pressures caused by ETD can affect vestibular function. Thus, the test results can erroneously indicate vestibular organ dysfunction, when in fact the vertigo symptoms stem from dysfunction of the Eustachian tube. Therefore, it is important that Eustachian tube function should be assessed before vestibular function to rule out ETD, which, if present, will significantly influence vestibular function test results. An important point to note is that the vestibular function test should be performed in a state where pressures in the middle ear cavities are well within normal range and perfectly balanced between the ears. To sum up, the ETD consensus statement is considered to be the principal authority on the disorder, and it was published just 5 years ago. I'd like to propose that alterobary vertigo be included in the ETD consensus statement as an official symptom of ETD, and that Eustachian tube catheterization also be recommended as a method for the diagnosis and the management of ETD. I would also like to reiterate that Eustachian tube function should be tested before vestibular function. To that end, I would like to invite you to publish case studies and research into cases of vertigo where Eustachian tube function was assessed before vestibular function. I believe such investigation may provide exciting insights which will impact our practice and improve patient outcomes. You can enjoy my recent article in the November-December 2021 issue of ENT and Audiology News magazine. I would like to express my appreciation to the magazine, and in particular the editor, who invited me for their special focus on space and extreme environments. Thank you for your attention.